I first of all apologize for starting this session late. We had some technical issue, and in the era of AI and high tech, we are still facing this problem. So thank you everyone for joining in. Good morning, good afternoon, good evening to all our distinguished speakers and participants joining us from across the globe. Childhood and adolescent obesity has become one of the greatest global medical crises in this 21st century. And we have our privileged speaker, Dr. Subodh Banzal, a renowned endocrinologist, professor and head of the Department of Endocrinology at Shri Aurobindo Medical College, PS Institute, Indore.
Yes.
A consultant endocrinologist, BHRC, Indore. He's the president of Endocrinology Society of India, MP chapter, immediate past president of RSSDI MP chapter, and held several leadership positions in advancing diabetic and endocrine care across India. Today, he's speaking about childhood, adolescent obesity, a global health emergency. I welcome with his expertise and insightful session for us. Sir, over to you, and I will just share the slides.
Thank you, Saurabhji. I remember Dr. Agarwal very much today, and thanks the International Journal of Clinic and Prof invite. Thank you very much. So I think we are going to start now. Can you share the slides, Dr.
Yes, sir.
Saurabh or Sukanya,
Yes.
please?
I will do that. I will do that. Hold on.
Thank you. Dr. Agarwal was very, very active during COVID time. Unfortunately, we lost him. I used to hear every day he used to talk about a lot. Thank you. I think this is very, very important topic to be discussed today, and that is childhood and adolescent obesity, a global health emergency, because these children are going to become the adults tomorrow, and it is going to create problems. So diabetes, hypertension, sleep apnea, and many other things they come with obesity. And the obesity usually starts from the childhood and it goes on. So this is what we are going to discuss today. And I think we are aware that pediatric obesity is one of the most important global health problem and public health problem, you should say. In fact, WHO has described it as one of the most serious public health challenges of 21st century. And we're going to go up again and again with that. Next slide, please. I think prevalence, if you see, it is going up. Patients are becoming overweight and obesity in pediatric age group, and it is alarmingly high. And it's not only in developed countries, but in developing countries like ours, Africa, Oceania, South America, people are going up and up as far as the weight is concerned. 2012 estimated WHO reports globally 40 million children younger than 5 years of the age are overweight. So see, the adolescent age, it's early age group 1 to 5, if they are obese, it is a problem. Can I have the next slide, please? Obesity is, according to WHO, is defined as a condition of abnormal or excessive fat which is accumulated in adipose tissues, and it is up to the extent that it starts impairing the health of individuals. So as long as the obesity is healthy, not a problem. Once it starts impairing health, it is a big problem. It gives rise to insulin resistance and many other problems which we'll be discussing further. Can I have the next slide, please? I think definition-wise, I already told you, is abnormal or excessive fat accumulation that impairs the health of individuals. We call it BMI, which is the index of weight for height, commonly used to classify overweight or obese people. BMI is defined as person's weight in kilogram divided by square of height in meters. So this is what BMI we call it. For the Western countries, it is up to 25. We have the next slide, which will show you the BMI of the underweight less than 18.5. Normal is 18.5 to 24.9. That is for Western. For India, up to 23.4. More than 23.5, we call ourselves overweight, and naturally over 27, we are obese. Here, overweight is 25 to 29, 30 to 35 is obese, and more than 35 is severely obese or extremely obese. And those who have more than 40 of BMI, they are extremely obese and they have problem. And if you see the children, it is age which needs to be considered when we define the obesity. Children under the age of 5, overweight is weight for height greater than 2 standard deviation above the WHO criteria for child growth standard median. And obesity for those who are greater than obesity, overweight is greater than 2 standard deviation, and obesity is more than 3 standard deviation above the WHO child growth standard of median. If you see the children who are 5 to 9 years of the age, overweight for them is 1 standard deviation above the median for the WHO growth reference, and obesity is 2 standard deviation more than the WHO growth reference. So you could make out that in the children it is 2 and 3 standard deviation, and between 5 to 19 years up to 10 years you call as 1 standard and 2 standard deviation overweight and obesity. Next slide, please. I think if you see the BMI percentile for the children and teens from the age between 2 to 20 years, those who are underweight, they have less than, see a percentile, see 5th to 95th and more than 95th percentile. So 5th to 85th percentile is they are healthy. If it is between 85th to 95th percentile, you call them overweight. And if they are more than or equal to 95th percentile, you call them obese. So this is the obesity for the teens as far as BMI is concerned. And I already given you other criteria for the other children as per the WHO reference. Next slide, please. If you see epidemiology wise, in 2019, almost 38.3 million children under the age of 5 years were overweight or obese. Once considered as a high income country group problem, now it is going up to middle income as well as in the urban settings of even the poorer countries, urban settings. Almost half of the under 5 years were overweight or obese in 2019 who lived in Asia. So Asia is also becoming a big problem as far as obesity is concerned, and coming days or years, these children will become adults and they will have more problems. Can I have the next slide, please? If you see over 340 million children, adolescent aged between 5 to 19 years, were overweight or obese. That was 2016. And while 1% of the children, adolescent between 5 to 19 years were obese in 1975. So 1975, 1%, here you see the percentage has gone up so much. And if you see the adolescent, 6% of girls and 8% of boys were obese in 2016. So 1% to 6%, 6 times increase. And if you see obesity is not a global health problem because 3.4 million deaths, they are caused by obesity or overweight only. And if you see obesity is an epidemic, the worldwide prevalence is going up. 1 out of 3, 30% of children were overweight or obese. And if you see number of countries with decreased obesity recent 33 years, not a single one. So all countries, all over the world, all over the globe, they are having obese children and they are growing up and up every year or so. Every decade you will see rise in obesity in coming years also. Now WHO something has to be done for that. Next, please. If you see in India, frank obesity is not that common as compared to West. But Asians, we are thin fat Indians because we have adiposity, because the central obesity is more, the central obesity, the obesity in our abdomen, and that is more centrally obesity we call it. It's a metabolically unhealthy and it is more dangerous. So Indians, they may look thinner as far as BMI is concerned, but we have less of body mass, I mean muscle mass, and more of a central obesity, and that obesity is not good because that is the cause for the diseases and problems in coming years. Next, please. If you see CBO in India, it was in Delhi, it was 2002 and 2004 data there, 31% were overweight, 7.5% were obese. In Pune, it was 24% of children were overweight. In Chennai, 22. So almost 1/4 of the children were, maybe it has gone up more. So urban India, elite class, and urban slums also having, they are fattening, and poverty and undernutrition is more now rural India also is having obesity in coming years, because the things have certainly changed in rural area also, because the machines have come in, all roads are there, people are walking on them. They don't walk, they go on motorcycles and tractors, and they have big cars. So in coming years, you'll see the obesity in rural area also. Next slide. It is, it costs a lot of money if you have to treat the obesity related comorbidities and problems. And people have estimated over lifetime childhood obesity costs $19,000. So you can imagine how many rupees it will be there per child. So if the children, they start obese, they end up having obesity, and they create problems over a period of time because they have other mobile problems. Next slide, please. If you see what are the causes of obesity, it is eating big portions, eating food which are rich in calories and nutriently poor, spending a lot of time in front of television and mobiles and computers, and spending too little time in outdoor activities. So that is a big problem as far as children obesity is concerned. Next slide, please. And it is because of the easy access to the food and junk food which is available everywhere. Fast food, so-called fast food, is a junk food. It is a calorie rich, but nutrients are not minimum. They are minimum. There are few opportunities for physical activity, lack of parks and playgrounds in many communities, because the urban areas are becoming crowded, and everybody is in the car or in the motorcycles, and very little space for the walking people, and the encroachment is there in the parks also. That is also a big problem in our country and maybe in other countries also. Next slide, please. Genetic factors, they play a role. If the both are, even out of two, one parent is obese, the chances of getting obesity in children is more. So as an adult, we have to take care of ourselves also. If both the parents are obese, almost you see it runs in families. So obesity will come in children also. Next. I think many drugs like steroids, some antidepressants, many other medications, on the counter medications, they can give rise obesity. Another cause, genetic, the lifestyle, the medications. Next. There are some endocrine causes of obesity like Cushing syndrome, hypothyroidism, hyperinsulinemia, pseudo-hyperparathyroidism, hypothalamic disorders, and some genetic disorders like Prader-Willi, Elmstrom, Carpenter, Cohen, and Lawrence-Moon-Weedel-Bartle syndrome. All these are the causes for endocrine and genetic causes of obesity. Next, please. There are some psychological factors which play a very important role. Depression, anxiety, people find solace in eating, or cooking food and eating, they feel comfortable. There are self-esteem is low. Those who have body dissatisfaction, they don't like their body, the thinness, and they become eating disorders are there in people. And these are also causes for the obesity. So you have genetic, you have drugs, you have the lifestyle, and you have psychosocial problems. And psychosocial factor is also very, very important. Next, please. Gone are the days when we used to, or people used to play outdoor games, and they used to have. Now, if you see the children lower down, they are sitting on the mobile and joysticks and playing the games, and they are watching television most of the time, and that is a big time killing as well as health killing problems are there with these gadgets. If you see childhood obesity, it starts from the early age. It starts from the video games, high fat food, study time is there, they have no action, they become mildly obese child, and they feel that they are too tired to climb stairs or do outdoor activities. Gradually, they put on more weight, and exercise becomes uncomfortable and painful them. And there comes a time when they become more obese and severe obese, and they have the comorbidities like the asthma, diabetes, musculoskeletal problem, and depression comes in. Esteem goes down. They don't feel like coming in the outdoor, and they don't want to talk to the people, and ultimately end up having obese adult coronary artery disease, pulmonary hypertension, pulmonary disease, diabetes, and hypertension, and it is a big cause for mortality also. So obesity starts from childhood. We have to take care of it. and see that it goes on well. Next, please. Poverty, if you see in Western countries, especially in US, they take cheaper food which are dense in calories, but they are not that good as far as nutrients are concerned. And if you see the fresh vegetable, fruits, lean meat, and they are more expensive and they don't last long, so people don't go for it. They go for high fatty meats. And if you see in third world, so-called third world countries, poor as having the other type of malnutrition. So this is the difference between a affluent society, the poor people in affluent society, and the poor people in rural and other areas. Next slide, please. If you see overweight, the kids, they become overweight adults. That's what I've been telling, and that is the relationship between childhood obesity and obesity in adults. So if you really want to control obesity in society as a whole, take care of children. That is very, very important. Next. I have already told you about all these problems which can come, the complications of childhood obesity, that is start from sleep apnea, asthma, fatty liver, renal problems, they may have hip problems, they may have joint problems, the painful, bored legs, they are because of osteomalacia and osteoporosis, they may have flat feet, self-esteem goes down, they may become depressed, headache, initially they feel good, and then it is a problem. They may end up having high cholesterol, blood pressure, sometimes the acidity problems or GERD. Some of the adolescents have the acanthosis nigricans and diabetes because they are having, sometimes because of the big fat belly, they have the backache, and the girls may have PCOD and irregular cycles and infertility having during their adulthood. So these are the problems which start early and they remain for a long period of time. Next, please. So what are the impact of health on naturally? I've already told you the same: heart disease, hypertension, osteoarthritis, sleep apnea, dyslipidemia, and type 2 diabetes. So obesity is not the only effect. It brings a lot of side effects and a lot of diseases with it. And ultimately morbidity and mortality is more. People have to end up spending a lot of money on the health problems. Next, please. There are some psychological complications of it, like emotional problems, body dissatisfaction, eating disorders, low self-esteem, and anxiety, and depression is also there with them. And if you go next, please. And this is the WHO wants to help people by reducing both non-communicable diseases and overweight. And if you see the children who are obese, they may have precocious puberty, delayed puberty, PCOS, hypothalamic problems, menstrual irregularities, and sometimes heavy bleeding could occur, and the puberty may come early. That's what we call it as precocious puberty. And understanding obesity and its impact on female reproductive system is very, very important for the future generations, because the children of the obese women, they are become obese later on also. So it runs in families and it goes in generations. Next slide. I think obesity, PCOD, I don't have to go in details, but it is the insulin resistance, which is the root cause for PCOD or polycystic ovarian disease, and they are having more problems as far as diabetes and cardiovascular problems are there. So it is a metabolic disease, we call it, and they may have, next please, menstrual irregularities. Next. In evolution, menstrual irregularities, insulin resistance, metabolic syndrome, cardiovascular problem, endometrium cancer, they come in and they have more prone to get pregnancy-related complications also. Next slide. I think there are some myths. People say overweight children will outgrow their fat and they become thin. No, 50% of overweight adolescent and over 33% overweight children, they become obese over a period of time. So 50% of adolescent and 33, that is 1/3 of the children who are obese, they become obese adults. And myth is obesity is genetic, nothing can be done. No, genetic predisposition to obesity can be modified by the environmental factors. So if you take care of lifestyle, do more activity and less food, certainly obesity may not run the families also. So these are the myths and there are facts. Next, please. So what to do? I think we have to manage it. By lifestyle, diet and exercise. I already told you there are drugs are available and they were there and some of them gone off market and they were centrally acting and non-centrally acting drugs. And people have a lot of bariatric surgery. Our institution in Indore, Mohawk, there is a big center for obesity here in Indore. And screening and early detection and management of metabolic complications have to be taken care. Next, please. Prevention and control. I think prevention it should begin in early childhood. The mother keeps feeding child looks very, goal matol and they look chubby and ultimately they end up having the problems in adulthood. So one should not be very, very facilitating by overeating the children because they are not sure how what to eat. So we start giving them green leafy vegetables, fruits from early childhood. We give them low dietary fats. Oily fish should increase consumption. Oily fish could be there. Those who eat non-veg, calorie restriction. If they are overweight, sodium has to be restricted. The salt has to be restricted, and we should not drink alcohol in front of them. And we should stop smoking also. If we do it at home, the children will learn, and they may have those problems in adulthood also. Can I have the next slide, please? Lifestyle intervention is very, very important. Low calorie diet, maybe whatever diet is there to maintain the body fat, we should reduce by 500 to 600 calories per day. People talk about VLCC, or what is that? Very low calorie diet. That is less than 800 calories, but they give up a lot of malnutrition, a lot of nutrient problems, and they should not be followed unless it is emergency. If somebody is following a very low calorie diet, not more than 12 weeks, and after 12 weeks, they should give up and go to the normal or lower diet. And certainly, we need multidisciplinary approach because one approach may not tackle the obesity. You need the exercise, you need the dietitian, you need the physiotherapist, you need the doctor, and no single intervention seems to be effective for long-term maintenance. Patient has to be psychologically ready for losing the weight and maintaining their weight. That is very, very important. Psych is very, very important here. Next slide, please. So exercise, it is led by example. If you keep talking about go for exercise and if you are not doing, you mean the parents are not doing, children will not learn. So as a parent, one should also start doing some exercises that will certainly encourage children and that will be example for them. Next, please. I think things have changed over a period of time. Next. If you see the portion size in 1960, 2011, and now, everything is changed. Almost 3 to 4 or 5 times the calories being served in the restaurants and others there, and people are taking a lot of trans fat everywhere. It is the bakery and samosa and kachori and whatnot. So and the meat and portion size, the cold drinks, the fizzy drinks, everything is having dense calories, and that creates problem with children. They like easy food, and this is how they are putting on more weight. Next slide, please. What is important? There's a 5 to 1 and 0 rule. What is that? 5 or more fruits and vegetables per day, 2 hours of less of recreational screen time. So one should not sitting all the time on mobile and TV, and 1 hour of more of a physical activity, and 0 the sugary drinks. Take more water and low fat milk. That's very important. You can take chas or buttermilk also. That is low fat. Next. And people should take other preventive measures like we should not give rewards that I'll give you treat. Don't give, choose non-food rewards. Have healthy snacks available. Sedentary life has to be reduced, and child should get enough sleep. And they should keep the fridge and pantry full of food, healthy food. If you keep a lot of sweets and other things in the fridge, and you expect children not to eat, but it's not possible. And encourage child, they should eat whenever they are hungry, otherwise not. And that the hedonic appetite has to go down, not to eat for pleasure. Drink water, not the carbonated drinks, not the beer and carbonated drinks. People are fond of taking colas and other fizzy. I'm just naming that, but the fizzy drink should be avoided. Next. Now, what is target weight loss? Target weight loss should be SMART, that is specific, measurable. You should be able to measure. Achievable. It's not give you unrealistic. It should be realistic and timely. That weight loss target should be set realistically at no more than half to 1 kg per week and should be agreed individual. So 2 to 3 kg per month, not more than that. Aiming 150 minutes per week of moderate intensity activity, 75 minutes of vigorous activity on 2 non-consecutive days per week. So we should give them enough activity, also 150 minutes per week. Next, an activity should be performed in 10 minutes bout also it can be done. 1,000 steps in 10 minutes and aim is to achieve at least 30 minutes daily on most of the days. We should minimize sedentary and screening and sitting time. So that is by sitting time all the time, not sitting on the chair. In between, you move around, stand, and you can sit and do some activity or something of that sort in these patients also. Next slide, please. You should be able to measure the fitness, weigh yourself, and look for the inches, how much inches you have lost as far as the girth is concerned, abdominal girth is concerned. Benefits of weight loss are many. Next, if somebody loses 5% of body weight, and endocrine system becomes better. Next, and the testosterone level goes up, the insulin level goes down, the sugar they goes down, insulin sensitivity is more, and the girls, the adolescent girl may start having ovulation, and that is very important. If they lose 10 to 15% of body weight, LH and FSH, and the menstrual cycle becomes almost regular. So that is very, very important. So there are a lot of benefits. The sleep apnea, the snoring goes down, and they live healthy. So the loss of weight is very, very important. And 10 to 15% of body weight may mitigate the impaired glucose tolerance and diabetes also. Next slide, please. There are medications which are available. Sibutramine, rimonabant, these were the drugs which we used to use, but because of their cardiovascular problem, depression, and other things, people have been withdrawn. These drugs have been withdrawn from the market. Now we have the other drugs which are available. I'll be discussing in next 1 or 2 slides more. Next slide, please. The orlistat is the drug which we call as a lipase inhibitor. What it does, it doesn't allow fat to be absorbed. 30% of the fat from the food goes out in the stool. So those who take, we should give them 120 milligrams 3 times a day orlistat. And it certainly, because if those who eat more fatty food, they will have the flatulence, they may have oily leak from the down, and they may have oily stool steatoria also. And if you are using these drugs, if patient is not losing 5% of original weight in next 3 months, don't give them. It's all useless. And if you are using it for long term, then one should take care of fat soluble vitamins and other nutrients also. That's very, very important. Orlistat is very much available. And now we have newer drugs which are weekly injectable, GLP and GIP receptor analogs. So next 2, 3, 4 slides I'll be talking, and then we will have some discussion or some question answer. Next slide, please. Metformin, people have used it. It is an insulin sensitizer. PCOD people are using, but it is weight neutral. It's doesn't cause much weight loss. So I think one can try it. PCOD and other things are there. Next. And lifestyle is very, very important with all these medications. Without that, it is not possible to do. Now we have the newer drug, Mounjaro, Yorpeak, that is GIP and GLP-1 receptor analogs. And these are the areas where you have these receptors in the pancreas and alpha and beta cells, in the heart, vasculature, immune cells, gut, and kidney. In addition, both GIP and GLP, they express areas in the brain and they give you good satiety. People feel satisfied with little food and they have the abdominal fullness comes with that. Gastric emptying goes down and the insulin secretion is more, glucagon goes down. So along with obesity, they are quite useful in diabetes management also. Next slide, please. And they have been approved in the children who are obese, having diabetes and more than 10 years of age. Next. Okay, another is the semaglutide. I think this Ozempic has become popular, and that is GLP-1 receptor analog. It is a class of drug which again works on the alpha and beta cells of pancreas. It works on the brain also, gives you satiety, fullness, the gastric cavity goes down, and certainly it is useful in obesity as well as in diabetes also. So these are the drugs which are using is injectable once a week, weekly doses, and they are quite popular. They have become recent times. And this drug, GLP-1 receptor analog, is next slide, please, has been approved in the children also, those who are obese and more than 10 and 12 years of the age. So that can be done. So these two drugs, 2022, it was approved more than 12 years of the age with overweight and obesity, along with lifestyle is very, very important. You really cannot remain with drugs. These drugs, they will have effect on the lean mass also, on muscle as well as the bone. So if you are using these drugs, one has to advise patient to go for exercise, both weight bearing as well as aerobic exercise. Can I have the next slide, please? In 2022, it was semaglutide, which was Wegovy, which was approved more after a step 10 trial in the children who were more than 12 years of the age. And certainly they are quite useful. Another drug, next. This is setmelanotide. This is another drug which has 8 amino acid peptide, and it activates some receptors in the brain. We call it the MC4 receptors in paraventricular nucleus of hypothalamus and lateral hypothalamus area, and both are important as far as appetite regulation and suppression of appetite is concerned. And FDA has approved them in the patients who are having obesity and more than 6 years of age with the 3 rare genetic conditions. What are those? POMC, LEPR, and PCSK1 deficiencies. These are the syndromic genetic problems where the setmelanotide has been approved. Next slide, please. Further, in June 2022, it was approved to include Barrett syndrome and certainly some rare genetic form of obesity. So there are people who are mentally subnormal, having multiple other problems of obesity, where these drugs, semaglutide, has been used. BMI by 18% in 1 year, it is reduced. It was seen in venture trial. So these are the newer drugs coming in coming years. We may have more and more drugs for obesity. Next slide, please. Surgical management, I think 2-3 slides on it. You have 2 types of bariatric surgery, we call it. Either what do they do? Malabsorptic, the absorption of the nutrient will not be there. We have restrictive, they cut down the sleeve gastrectomy, they call it. They make the small stomach small, or combination of them. Sleeve gastrectomy with malabsorption. Next slide will show you the bend, the sleeve gastrectomy, as well as Roux and Y. So there's 3. I don't need to go in details. And third one is they make the small pouch of the stomach and they cut and they join it lower down. So the absorption of food goes down and they have malabsorption and they lose weight. Diabetes also goes in remission in many of these patients. Next slide, please. There are complications of these surgeries, stenosis, leak, abdominal discomfort, sleep, many problems could come in. So one has to be very, very careful. If the indication are there, then only one can go for sleep or this bariatric surgery. Next slide, please. So concluding of my talk will be, it is the childhood and adolescent obesity is a big problem and it's growing issue, and society, we have to focus on prevention of it. A combined diet and physical activity conducted in communities with school as a component will be more effective in preventing obesity and preventing adulthood obesity also. Parents should enforce healthy lifestyle at home. They should focus on causes. Over time, decreased childhood obesity leads to healthier society as a whole. And I think that's the end of my talk. Can I have the next slide, please? And then we should not take only half plate of non-starchy colorful veggies. That is very important. 1/4 plate should be of carbohydrate, that potato, pasta, rice, or kumara, and 1/4 plate could be of protein that may involve chicken, tofu, fish, or meat, or vegetarian sort of things. I think thank you very much for your attention. Thanks a lot, Saurabh, and the society for inviting me. Thanks a lot. Over to you, sir.
Let me just close the slide. Thank you so much for the insightful information about this topic, which is a need of an hour. I think everyone in this world is facing this problem. Obesity is something which is a concern starting from the childhood and goes up to all the ages. So I welcome everyone for the question answer round. Please go ahead and ask your questions from the speaker.
May I ask, Saurabh?
Sure, go ahead.
Please go ahead.
Thank you very much. Thank you very much, Professor Saab, for a wonderful
Thank you,
talk.
sir.
It is very impressive indeed, and that is the need of the time. But one thing what we are facing, just to introduce myself, I am Dr. Nizami. I'm from Lahore, Pakistan. And certainly, but we are facing the same issues what you face in India or Bangladesh, Pakistan, Sri Lanka. We are having the malnutrition and stunting growth. That is a major issue rather than the obesity. Obesity is a problem or issue of those who are blessed by the Almighty. So that is their issue indeed. I have a simple question that what do you feel about the complications? Likewise, now it is a very moderate to use the Ozempic or like Majura or so on, these injectables you have said. I agree with you that there are the more complications if we go for the surgical intervention or what we are doing so. So just it is my interest or simple a question to you, sir, with appreciation, that what do you find as a renowned endocrinologist that the complications of this Ozempic or so on? Thank you very much.
I think these are the good drugs, especially in children if they have diabetes and obesity, acanthocytosine overeating, then one can use. But I think at the same time, it is the nutritional deficiency will be there over a period of time, and they may lose their lean mass, and that is the muscle as well as the bone. So one has to be careful about the exercise. If you just sleep and don't eat, certainly whole body gets problem. And once you stop these medications, the muscles which was using the glucose will not be there, and then more problems could come up. So these drugs are there, but they have to be taken long term, and they have to be taken with pinch of salt. And the real indications are there, not the over the counter. We should go and buy and start injecting. So that's what I feel. Thank you, sir.
Yeah,
I also have a question. I have a question.
Yes, madam.
I'm Dr. Kiran.
Go ahead, please.
Kiran, can I conclude my question, please?
Ashraf sir, बोलिए, फरमाइए. Yes, please.
बहुत शुक्रिया, Kiran. Thank you
Can I
very much.
ask one question?
Kiran,
I think we need to wait for our turn. Yeah,
just
go ahead.
I was asking about the complications. That was Professor Saab. I mean, eyesight or so on the complications. As far as the musculoskeletal issues are concerned, indeed it is there. But about the eyesight or so on, because they have been problems or issues.
Eyesight is not the real. If you control diabetes very well, those who have underlying retinopathy, otherwise also in them
not about that.
So it is not true. And pancreatitis is not seen, that pancreatic carcinoma is not seen in the. So it is as otherwise also patients with diabetes, they are more prone to get those problems. So if the studies have been shown, they don't give rise any increase in retinopathy or pancreatic problems. So that is very important. Sometimes the main concern is the GI side effect. They may have nausea, vomiting, diarrhea, lack of, that is there. So those things will remain, and within a week, 2 or within a month, they go down. So serious complications will not be there, but I will be careful about. So not use these drugs without indication. That's very, very important.
Yeah. Thank you very much, sir. Thank you, Kiran, for giving me this opportunity. I'm grateful.
I just let me ask one question, please. There's certain medicines like antidepressant, telmisartan, and sulfonylurea. They all cause weight gain. So if we have to take these medicines, what can we take to reduce weight as preventive measures?
Madam, if the patient has telmisartan will not give rise any weight gain. Antidepressant, antipsychotic, yes, they can give rise. The sulfonylurea, the patient usually is diabetic, and then if they are overeating and if they get hypoglycemia, then the weight gain is more. Either because of diabetes, if they have lost weight, that may come back again. So the whatever weight was lost because of diabetes, they may regain it. But if they are not treated properly, that is not good. So the answer to your question is, if they are diabetic, metformin, the SGLT2 inhibitors like dapagliflozin, empagliflozin, and these drugs, Ozempic, the GLP-1 receptor analogs, these are the good drugs to mitigate the weight gain, and they don't give rise weight gain. So one has to consider the weight. You will see the diabetic with insulin also there's some weight gain. Sulfonylurea and weight and insulin, they are more prone to give weight gain, but metformin, SGLT2 inhibitors, and these GLP-1 receptor analogs, they don't give rise, rather the patient may lose weight. Pioglitazone also notorious to give rise weight gain. Dr. Kiran, thank you.
No, but semaglutide and empagliflozin, they didn't suit. They didn't suit. They caused allergy.
If they are not suiting, that is a different problem. You don't increase the dose suddenly. You go low, go slow, and then gradually step up when the patient is comfortable. So semaglutide and tirzepatide, these are the good drugs, madam, as far as diabetes and obesity is concerned, treatment.
Thank you.
Saurabh?
Yeah, can we, Dr. Angelique, you want to speak something? Dr. Pillai? Okay. I think in the interest of time, I think we already crossed 10:30.
Yeah.
Yeah, in the interest of time, I believe you're in the hospital. So we will like to wind up this session, and I thank you, Dr. Subodh Banzal, for enlightening us with this wonderful session. And with this note, we would like to take a leave. Thank you so much, everyone, for tuning in. Thank you, everyone.
Thank you, Saurabh, and all the colleagues. Thank you.
Thank you.
Thank you.
Thank you. Bye.
Have nice. Thank you. Have a nice day. Thank you.
Thank you. Thank you, remembering my friend Agarwal also. Thank you.
Thank you, sir. Yes.
My great leader.
Right.
Yeah.
Same here. Same here. Thank you.
You are welcome to Lahore.